Our next speaker is going to be Haney A. Malamet, and he's going to talk about the critically ill pregnant patient.
Good morning, beautiful people. My name is Haney Malamet. I'm from Baltimore, Maryland, but I'm going to change the state's name to Malamet when I'm done with it. So today I want to talk to you about the critically ill pregnant patient. Now this is a trauma session, and that's all right. This is an approach that you can take to any critically ill patient, whether it's medical or trauma, because what I want to give you today is a general approach. There's some really simple things that you can do for these patients. They don't cost any money, but you'll improve the outcomes of any patient that you see. It's really all boils down to this. There are a lot of changes that happen during pregnancy, but the ones you really have to focus on for the critically ill patient, the things that are going to kill your patients, are perfusion and diffusion, the circulatory system and the pulmonary system. And that's really what you have to focus on when those patients first present to you. So there's a lot of changes, but the really big things that happen is that your cardiac output increases by up to 50% by the third trimester. And you're saying 50%, wow, that's pretty good. How can anyone be critically ill with so much cardiac output? The problem is that these patients are riding a fine line. This cardiac output mostly goes into increased perfusion of the placenta. 25% of that perfusion goes into the placenta. So even at baseline, with that super therapeutic cardiac output, you're having a lot of it go to the placenta, and so these patients, even stable, are riding a fine line. They have very little reserve. And the same thing happens for the lungs as well, little reserve. The mom has to be more tachypnic to breathe because she's breathing for 2. So the red blood cell mass increases because there's no way you can put more oxygen into the blood. CO2 drops because of the tachypnea. You have to breathe faster, get more oxygen, so CO2 drops down, and this is absolutely normal. But here's one of the biggest things that happens during pregnancy. Day by day, week by week, as that fetus enlarges, it's pushing up on that diaphragm, and it's collapsing those lung volumes. And that decreased lung volume causes decreased reserve. And specifically, we're talking about the FRC. This gives you your apnea time. And so this reduction in volume is what's going to kill patients when they present critically ill. And they desaturate faster, even when they're looking well, and especially when you're about to intubate them. So what are our goals for the pregnant patient? A couple things you got to keep in mind. Good old MAP of 65 is the best evidence that we know. If you have a patient that has chronic hypertension during pregnancy, that's okay. You need 80% of their target systolic or MAP pressure is your target when you're resuscitating those people. So 65% MAP normally, or 80% of their known blood pressures. What are the goals for the lungs? Very simple. You need a PaO2 of 70 millimeters of mercury. Please don't do ABGs on these people. Get your pulse ox. If your pulse ox is greater than 95%, then it's all good. Once you start getting to less than 60 or 90% on your pulse ox, now you start to have problems. Not only problems for the mother, because remember that FRC is down, so you're going to desaturate faster, but it's also problems for the fetus. That fetus needs a rich oxygen state. CO2, things you want to keep an eye on, a PaCO2 of 30 to 32 is normal. So if you have Entitleon or if you happen to get a blood gas on these patients, this is what's normal. When it starts to get to the normal values, what's normal for us non-pregnant patients, that becomes a problem because now this person is having a loss of reserve. They're starting to fail on you. This is like the asthmatic with a normal PaCO2. And what's worse is that this causes an acidotic state, and you get vasoconstriction in the uterine arteries, and you have decreased perfusion for the fetus. So how are we going to treat these people? These are the goals. What are you going to do for them? Give them the fluids that you would normally give them. Give them the same lab tests that you give to them. Give them the same medications. Do the same radiation, top to bottom. Now, I'm not suggesting that you irradiate every pregnant patient that comes in, but you can do a full CT evaluation on a pregnant patient and still be within a safe range. So do what you would normally do for the mother, and that will help protect the fetus. In fact, you should only resuscitate the mother. That's your best goal, and the fetus will be assured good perfusion. So what do we have to do differently? Well, here's the mnemonic that'll remind you what you need to do. You want to tilt the patient, left lateral decubitus. You want to give them lots of oxygen. You want to get good lines in and lines above the diaphragm. And you want to know the dates, and you want to get on the phone with labor and delivery as soon as you can. So let me go into this in a little bit of detail. Tilting the patient. After 20 weeks, you get this phenomenon known as the supine hypotension syndrome. This uterus is getting bigger. It's pushing down the IVC and aorta, and you can reduce your cardiac output by up to 30% just by laying supine. So the first thing that you should do when you have a patient who's critically ill or even looks critically ill is just turn them on their left lateral decubitus. Get that uterus off of those great vessels and improve perfusion, just as you see here. Very simple to do. It costs you nothing. The next thing to consider is get oxygen on. I think this is something we're good at, getting oxygen on early on the patients. So you go ahead and put 100% non-rebreather face mask. You can also use this. Does anyone have this high-flow humidified nasal cannula? Anyone has this? This is a really great device. You're going to be seeing more of it as it comes out mainstream. But this is a high-flow nasal cannula, can give you up to 60 liters of flow. And it's not so much the oxygen flow, but that flow provides you with a little bit of PEEP. I call it diet CPAP in our department. It's just a little bit of CPAP, about 4 centimeters of water, just to splint open those airways and provides good oxygen. How about non-invasive ventilation? I would recommend against the use of it, and here's why. During pregnancy, with that enlarging uterus pushing up, you're getting increased intragastric pressure. The hormonal state of the pregnant patient causes relaxation of the lower esophageal sphincter and decreased intestinal motility. So these patients are a high risk for aspiration. And now you have somebody who's in a lot of respiratory trouble, and now with vomit in the airway, it's only going to get worse. So try to avoid non-invasive, tight-fitting masks at all costs. Try to use high-flow humidified nasal cannula if possible. Let's talk a little bit about lines. Now, these people come in sick. We want to get quick access, things like IO, maybe femoral if you have access to it. But I really ask you to think twice about this, because that fetus, that uterus, is going to play a problem again. It's going to push down on those pelvic vessels, pelvic veins, pelvic arteries, and now it's going to be a lot harder to get medications and blood into that patient. So consider putting all lines above the diaphragm. You only need good 16 or 18s in the AC when you're resuscitating, and if you need to give pressures and all that other stuff, then go for the high vessels, go for subclavians, go for IJs. But everything should be above the diaphragm, even your IOs. And then finally, know your dates and call labor and delivery early on. Now, what are the important dates to know? Really greater than 24 weeks is a date that you want to know, because a couple things happen here. We already talked about the supine hypotension syndrome that happens after 20 weeks of pregnancy, so that's an important thing to know. You want to get your consultants on board, because you're going to have to get them to give them their monitors. You don't necessarily need their cognitive skills. You just need their monitoring and their nurses to interpret the fetal monitoring. And then finally, because they're going to be there's potential for life there after 24 weeks, you may consider delivery if this patient is critically ill. You can use apps, you can use OB wheels, but I really recommend ultrasound. It's the most definitive way of dating that fetus, and sometimes with multiple fetuses, the dates would look further along, but there's actually multiple fetuses there. So consider using ultrasound early on. Hopefully you're already having the ultrasound machine at the bedside to evaluate other things in this critically ill patient. And then finally, get on the phone. Again, not so much for the consultants to come down, because you want them to bring the monitors and figure out what's going on with the fetus. So here's your mnemonic. You want to do it together? T is for? O is for? L is for? D is for? All right, all right. Let's talk about the crashing patient. So now we have a person who's certainly sick. What are we going to do for this patient? Controlling the airway first. Remember, these patients have low reserve, that reduced FRC with that growing fetus, so they're going to desaturate faster on you. So you have to move quickly. These are going to be difficult airways. We'll get into it in a little bit, but the progesterone, the estrogens, they make these mucosal membranes very hyperemic, and they bleed very easily. Also, the distribution of fat in the neck and the enlargement of the breasts make these airways very, very challenging. And then finally, you want to fully prepare for these airways. You want to have everything within arm's reach, not the video scope across the department, right there next to you and ready to go. You may only get one shot at this. Application of oxygen early on. Hopefully you're already doing this because you've identified this person as sick. But certainly if you want to use apneic oxygenation, which I'm sure you've already heard about, 15 liters of continuous oxygen during paralysis, during your attempts of securing the airway. You want to ramp your patients up. You want to get ear to sternal notch. That's going to get you a better access to deliver that tube. And then remember, getting back to the airway in a pregnant patient is like a box of chocolates. You never know what you're going to get. All right, so remember, there's a lot of edema, there's a lot of hyperemia. Here's an example of an airway in a pregnant patient. That doesn't scare you? How about this? Just treat these like burn airways. Sometimes you can look down and it'll be a perfectly nice, crisp airway, but sometimes it'll look like this. So you have to be prepared for this. So who takes the first look? Does Doogie take the first look, the intern? I wouldn't do that. I'd get the most experienced clinician in the department to do it, and if it's someone else besides me, I'll let that person do it. But the most experienced person has to do it because they may only get one look at this airway. And you want to start as small as you can, have multiple tubes loaded up and stylated, ready to go, because once you take a peek inside, you may opt for the smallest tube you can, and then you can always bougie over and change it out. And then have your plan B, C, D, E, F, and G all ready to go. Once you intubate them, your vent settings, not much change than the non-pregnant patient. You want to go for an ideal body weight, 6 to 8 cc's. Ideal body weight, remember, is based on height and gender. And in this case, there's only one thing to remember. It's a female, so height and females. And don't remember formulas. Just look in your PDAs. Some people have a card on their ID that tells you what ideal body weight is. You may want to opt for a little bit more PEEP on these patients. There's no firm data that tells you where to go. I start with a PEEP of 10 because these patients, remember, are having that uterus pushing up, and you want to use that PEEP to push back down and expand up those airways. So a little bit more PEEP for these patients. And finally, keeping an eye on your peak and plateau pressures. Remember, we like plateau pressures to be less than 35, ideally less than 30. Post-intubation, ramp your patient up, keep the head of the bed elevated. If they can't do that, then reverse Trendelenburg. Big aspiration risk, even post-intubation. So keep the head of the bed elevated. It's also going to help with the performance of the diaphragm in the lungs because of that belly that's pushing down on that diaphragm. So by releasing that uterus and that belly off the diaphragm, you're going to allow better performance during respiration. So let's end up and talk about the patient who's coding on you, the really, really critically ill patient now. CPR in the non-pregnant patient is not exactly the same as the pregnant patient. Circulation put out an update to the CPR guidelines back in 2010, and they had a special section for pregnancy, so you know it has to be important. You know what they said? Compress at the same rates and same depth. Shock at the same dose. If they have a fetal scalp monitor, maybe take the scalp monitor out so you don't shock the little guy in there. And meds, use all the same meds. Consider not using amiodarone because of the iodine in that drug can actually pass on to the fetus and cause thyroid issues. So what's the difference? The same difference that we talked about before. Tilt them, give them good oxygen, get good lines in above the diaphragm, know your dates, and call labor and delivery. Let's talk a little bit about tilting because it's not exactly the same. Imagine trying to do compressions on a patient like this. Your downward force is not going to be as good as if you did it perpendicular. So how are you going to do CPR in these patients? You're going to find all those people that seem to find their way into your codes who are doing absolutely nothing, just wandering around, making a lot of noise. Do you guys have those people? We have them in Baltimore. Right? All those people that are just in the way, put them to work and have them manually decompress that uterus off to the left. And this is going to do the same thing as tilting them off to the side, and now you can do more forceful downward compressions, more effective compressions. There's some suggestion that pushing a little bit higher up on the sternum might help things because everything in the thorax is pushed up as pregnancy progresses. So pushing a little bit higher up might help these patients get better compressions on the heart. And the final thing you have to be mindful of is that when that person loses their pulse, you have 4 minutes before you have to consider doing a perimortem C-section. How many people in this audience have ever done a perimortem C-section or been around one? It is a terrible, terrible thing to see and be a part of, but it can save a life. So you have to be ready to do this. If you get the baby out and you get the placenta out, you can get circulation back to the mother by up to 80%. 80% increase in cardiac output. It is only about maternal resuscitation. We're not going to go into the ethics of delivering a baby to save that life, but it's really about maternal resuscitation here. And if the patient is less than 20 weeks, there's no need to even consider that because the fetus is not big enough to cause compression of those great vessels. So it should only be done if the fetus is greater than 20 weeks. You have to commit to it once you decide to do that. It has to be done in under 1 minute once you make the decision. 4 minutes after losing the pulse, 1 minute to complete it, and CPR should be continuing while you're doing the incision. So you have to be very, very cautious and very, very careful. It could be a very dangerous procedure. So there's a video out by Jason Wagner, which I'll show you in a second, but shows you that all you need is 2 tools, a scissors and a scalpel. That's all you need. No fancy setup, no fancy gear. So Jason Wagner at TechDoc has the simulation video showing that you're cutting from the subxiphoid all the way down to the pubic symphysis. This is not like a bikini-type incision. Just cut all the way down, cut down through the muscles, through the peritoneum, until you find yourself at the uterus. You may consider if you have time to put a Foley in to decompress the bladder. That's one of the most frequently injured organs. Then make a little nick with the scalpel at the uterus head, and then cut down. You can use 2 fingers to protect the baby. Deliver the baby. Don't forget to deliver the placenta. And there you go. Clamp and you're good to go, but don't forget to deliver that placenta. Some important things to remember is if you get return of spontaneous circulation, don't forget to suture up those wounds, because now you'll have a different type of shock. You'll have hemorrhagic shock on top of cardiac arrest. Targeted temperature management, really, really important. The data's not great. There's a couple case reports when we were using 33 degrees Celsius of patients having good neurologic outcome, so these patients should be no different. And don't forget to get your consultants down. You'll need someone to consult for the baby. You'll need someone to suture up the wounds if you're too busy, so get general surgery or OB to come suture up those wounds so you can focus back on the resuscitation of the mother. So there's just some simple things you need to do for any patient that's critically ill or with the potential for critical illness. And just to review, don't forget the mnemonic told. It's very simple to do. It costs you nothing, and you could change everything in terms of the perfusion and the pulmonary dynamics of that patient. And don't forget about the perimortem C-section. It's scary, but once you decide to do it, you have to commit to it. You have 1 minute to do it. Make your incision quick and fast, and don't forget to suture them up, and hopefully you can save that pregnant patient's life. So with that, I want to thank you all for your attention. Please reach out to me on Twitter or email if you have any questions at all, and I want to thank Mel and the rest of the staff for having me here today. Thank you.